Hello, my name is Dr. Jeannie Bailey, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for this episode 3 of a 3-part CEMO cast series on the best practices in opioid use disorder, also known as OUD. This one is entitled Optimizing Long-Term Outcomes for Patients with OUD, and we are going today talk about the best practices for applying extended release MAT or medications for OUD in the real world settings. This activity is brought to you by CME Outfitters, which is an award-winning accredited provider on continuing education for clinicians across the globe. I'm Dr. Jeannie Bailey, and I am a clinical associate professor of psychiatry at Brown University in Providence, Rhode Island, and I am also the Director of Research and the Director of Medications for Addiction Treatment at Stanley Street Treatment and Resources in Fall River, Massachusetts. Our learning objective for today is to apply evidence-based strategies to initiate the use of extended release medications for opioid use disorder in the real world setting. It's an ability to help us support recovery for individuals with OUD. First, I just want to do a quick summary of some of the data looking at what we know about survivors. And when you look at this slide, it tells you the information that was gathered by looking at individuals who had had an overdose and looking at whether or not they had received any medication prior to their overdose, and if so, which medication, and if after a near fatal overdose, they had actually received any medication after the overdose. And you can see that we do a very poor job, that less than 8% of the people who had a severe overdose received buprenorphine, and either a smaller amount, even smaller amount received methadone, and a painfully low amount received naltrexone. This is data that was generated from Massachusetts, where 7 individual data services are linked. So we're not doing a very good job of treating these individuals that are at high risk. What are some of the reasons why people are not using medications? Well, from the clinician's point of view, there's a real genuine lack of knowledge or training. People don't have confidence that they can initiate people onto these medications safely. And frankly, there is a prevailing bias towards wanting people to be opiate-free or the absence-based treatment model. In spite of data that lets us know that this model does not result in success and it has a high rate of overdose death, people still continue to think that we maybe are just substituting one drug for another when we use these medications. It sort of demonstrates a lack of understanding of the disease state and what addiction really is. Many people don't prescribe these because they're concerned about diversion, and there's frankly a lot of stigma about our patients. And in general, people's offices are busy and they have a lot of challenge with the resources that they have already, and they feel like they really don't have the patient interest and the support staff to manage these complicated patients. When you look at the patient's point of view, many of them just don't have information about the medications, and they have grown up in a world in which the use of medication was looked at as substitution, and therefore they have their own resistances and their own biases against using them. There's often in many states issues with cost and access. Patients worry about whether they're going to actually go into withdrawal if they start these medications. And frankly, they have a lot of stigma around seeking medications and all of the activities that are involved in engaging with the medical profession at all. When you look at what goes on for the clinician and the patients and the different perspectives, there's a whole array of things that can happen. If you're a physician, you may just think that if you have a patient in heart failure, you can call, get them seen, and have an appointment for them within a day or two. That's certainly not the resources that are available to these individuals with OUD. And it makes it quite frustrating and makes it something that really is very difficult for physicians to treat. Some physicians recognize that the more knowledge they have and the more that they can educate themselves and their office staff, the better outcomes that they have with these individuals. People feel like they don't know how to even do screenings, much less do the treatment. They're hard to understand how to understand what the disease really is. When you take a patient's point of view, they often feel that coming off drugs they're often not in a very good mood. They know they're irritable and difficult to be with. And it is only occasionally that people in the treatment world understand it. This individual stated that when a staff member took him aside and actually talked to him, it made him feel better that someone really cared and understood what he was going through. And that certainly leads to a better therapeutic outcome for all of us. This other patient stated that her doctor was really good, that he knew what addiction was, and that he gave her information about what her options were. So what medications really are available to us? The FDA has approved 3 medications for the treatment of this disease: methadone, buprenorphine, and naltrexone. Methadone is a full MOUD agonist. It's available in multiple different formulations, but for the treatment of opioid use disorder, it must be dispensed in an OTC, or an opioid treatment center, which is a highly regulated, structured clinic. Buprenorphine is available as a single agent or with the deterrent naloxone added. It is a partial MOUD agonist. It has multiple formulations, which range from a daily tablet to a 6-month implant to an extended release monthly injection, as well as another injection form, which has tentative FDA approval, which has weekly and monthly injections. If you add the deterrent naloxone in it, however, you have it available only as a sublingual film or tablet, and it requires a daily usage or daily ingestion. Naltrexone is a MOUD antagonist, so it's interacting very differently with the MOUD receptor. It comes available in a pill form, but largely for this disorder is used as an extended release injectable that requires an intramuscular injection every 4 weeks. As I said, these medications interact with the MOUD receptor differently. A full MOUD agonist, such as methadone, activates the receptor. It's highly reinforcing, and it has includes most of the abused types of medications, from heroin to methadone. A partial MOUD agonist activates the receptor, but it has a ceiling effect, which we're going to demonstrate later. Therefore, it's less reinforcing and it's less abusable, but it's also safer. It's less likely to cause an overdose. And in this partial MOUD agonist category, we have buprenorphine, which is available to us to prescribe in our offices now as a result of DATA 2000. The antagonist occupies the MOUD receptor without activating it. So it's not reinforcing. The individual is not still tolerant to an opiate, and it blocks the abuse of any other agonist that's put into the system while the antagonist is present. This includes medications like naloxone and naltrexone. This diagram sort of gives you another picture to think about this. If you realize what the activity is here, as the dose increases, the impact or the response increases of a full agonist. When you get up to the top, we have a ceiling effect. It looks like a ceiling effect here, but it's because the person all the receptors have been saturated, and in fact, that would be consistent with death. So people would stop breathing well before 100% of their receptors occupied. The partial agonist, as you see here, does have a ceiling effect, and therefore, it's only in the presence of additional CNS depressants like benzodiazepines or alcohol that we see a real overdose in buprenorphine. When you look at an antagonist, you see no activation. It's a flat line here. So you have no activation of the MOUD receptor. There's advantages and disadvantages to these medications. As you might imagine, that methadone is provided to individuals who need more structure and need more support, and it's highly effective for these individuals. They have to come regularly to the clinic, most of them every day. It's only after demonstrating compliance and improvement that they can get take-homes. But they also have additional services on site, and it's very unlikely that people will divert their methadone. Again, it's a medication that has a lot of stigma with it. It's the burden of going every day, having to be seen every day. There are some medical complications and interactions with other drugs, so it needs to be monitored for potential cardiac problems. But by and large, it is a safe medication when used in the settings that it's currently used in, and it saves lives. The advantage of buprenorphine is that it really is safer, as I mentioned earlier, and it's available for us to use in our offices. It does require that the person in the current formulations in the sublingual have to adhere to daily use, And therefore, there is often the fear of diversion. People sell or share their medications with other individuals. However, I would like to say that diversion is a problem. It is also well known that diversion is also a symptom of poor access to treatment. That when you increase treatment availability slots, you see diversion go down. Very few people really want to divert the medication. They give it to someone to keep them from using a needle and to keep them from getting sick. The other disadvantage to daily dosing is that people can stop and start and bridge themselves from illicit use into protected use. And children can ingest these when they are in the sublingual form. If someone has to have pain management, it also can be problematic if they are on a partial blockade. It's our belief that some of the extended release formulations that are now available will take care of many of these adverse concerns for the buprenorphine. So naltrexone also has some advantages and disadvantages. Clearly, an individual is not addicted to an opiate and there's no risk of diversion. It's administered directly by a healthcare provider. And it is a real option for individuals who do not want to be on an opiate. And they're individuals who have failed at methadone and buprenorphine and find that they want to have an option that's different. And they're people who really have a strong belief system that it's the best medication for them. So it's a true option. Some of the disadvantages are that you have to be opioid free before you can receive the injection. This time of being away from opiates needs to be 7 to 10 days. That's often a very risky period, and it's a difficult, heavy lift for many individuals who've been using illicit opiates. We find that people who believe, and there's this worry that when you've been suppressing your mu receptors with an antagonist over time, that you are much more at risk for an overdose death if you stop the medication and resume illicit use. Some of the studies we have had over the last year do not confirm that fear, but theoretically it is a disadvantage. And if you require pain management, it's very difficult to take any kind of opioid for pain if you have an antagonist on board. So now let's look at some of the strategies that you might utilize to try to help get individuals onto medications. As I mentioned earlier, one of the big hurdles for extended release naltrexone is that the individual has to be free of opiates for 7 to 10 days. People are trying to come up with ways to make this easier, and this is data from a multi-site study which randomized individuals into 3 arms. It was an effort to see if using low-dose naltrexone and rapidly descending doses of buprenorphine taper versus using would be helpful. And in order to test that, what they did was give people either active naltrexone or placebo naltrexone, and they gave them buprenorphine or placebo buprenorphine, and had a short dose of no buprenorphine if you got placebo, or a rapid descending dose of buprenorphine over the first 3 days. And in the other 2 groups, they were either given small doses of naltrexone at the 0.25 milligram dose, and that could be repeated as much as once a day, or they got placebo doses of low-dose naltrexone. And the effort was to see if adding this low dose of naltrexone would ease the transition from buprenorphine onto extended release. What they found was that, unfortunately, the study did not demonstrate that the use of any of these low doses of medications or the taper itself made any significant difference. In the 7-day detox, the naltrexone alone or naltrexone with buprenorphine provided the same and or similar rates of induction onto extended release. So the same number of people, as seen in this first item here, were able to step off of the oral buprenorphine and onto the injectable new naltrexone. The other thing that was important about this study, however, was that the individuals who received the extended release did feel that once they were on it, that they tolerated, they had fewer cravings, and that the individuals who got the fixed dose of, and all of them did get fixed doses of ancillary medication, also found those to be quite effective. So the ancillary medications helped the people tolerate the transition time, and they were given blinded fixed doses of clonidine at 0.1 TID, trazodone 100 at bedtime, and clonazepam 0.5 milligrams TID. So the take home from the study was that the short transition is possible even without the use of the medication, and a rapid taper if you provide ancillary medication. If you'd like to be inducted onto the long-term buprenorphine, which is available to us now in the United States in the form of Sublocade, you really have to decide if the patient is medically stable and if they really want to be on an injectable. They can come to you and be on an illicit opiate, or they can come to you from your actively stable buprenorphine maintenance population. The FDA has approved 2 formulations, 300 and 100. It's a subcutaneous injection, and once someone has been determined that someone is medically stable for buprenorphine and is a candidate for buprenorphine, or has come to you from their clinic, there's just a regular induction onto sublingual buprenorphine that's necessary. Everyone receiving the injection has to be on at least 7 days of sublingual. The dosage range needs to be from 8 to 24 milligrams. The shot is administered usually starting in the upper quadrant of the abdomen. It is an abdominal injection that requires subcutaneous injection every 28 days. And it's just, you're instructed to use the rotating upper and lower quadrants of the abdomen. After receiving 2 doses of 300 milligrams, people routinely step down to 100 milligram injection and then continue on that if it provides adequate MOUD blockage for as long as the individual wishes. If they find that once they step down to the lower dose that they have a resurgence of cravings or urges to use, you can reinstate the 300 milligram shot most likely. That's the standard practice. After someone has been on the medication, you just continue to rotate the sites. And if they require a 300 milligram injection, it is recommended that you do monthly LFTs. So you need to just be a little bit more cautious about the impact on the liver. As with all of these medications, you try to continue to provide a multidisciplinary psychosocial treatment alongside these medications. So what are the take-home messages and what are our SMART goals for today? We urge that you try to apply results from real-world studies, that the use of these medications are really the best practices for your clinical practice. These medications are effective and life-saving. The other is that we want you to know that the efforts and that there are many ways of trying to implement different strategies for the initiation of these medications in the real world, and that the use of some of these implementations may make it much easier to step off of buprenorphine and onto extended formulations. And thank you very much for joining us today for this episode 3 of the 3-part CMEO cast series. And for additional episodes on the role of extended release medications for the prevention of OUD, please look at our website at www.cmeooutfitters.com. You can access our educational hub there, which is a premier source of educational materials that range from animations to over-the-counter resources, as well as a number of tips and tools that you can use with your patients, as well as other caregivers and parents.